And welcome to the Nonprofit World TV show. I am your host, Donna Hagigat. Today we are fortunate to have three guests with us who are going to help us learn more about the opioid epidemic and what we can all do about it. To my right, we have Shawn Lang, who is the Deputy Director of AIDS Connecticut, and she also sits on the working group for statewide opioid prevention. In the middle, we have Sarah Howroyd, who is the founder of Manchester Hope Initiative. We have John Lally, who is the Executive Director of Today I Matter. John has lost a family member to the opioid epidemic and is also an APRN who has the ability to prescribe opioids, so he brings a very interesting perspective to our conversation. Welcome all to our show today. I'd love to start with you, John, to tell us the story about your son, Tim, and how you first became involved in the opioid epidemic on a personal level.
Well, yes, I did become involved because of my son's problem with substances. Mm-hmm. My son, Tim, suffered from anxiety and depression. Mm-hmm. That was very difficult to treat. And he went through lots of different treatments and therapies and trying to find some way that he could feel good about himself. Mm-hmm. And at some point, he turned to substances. One thing I've learned, my son was a cook. He worked in lots of restaurants. Mm-hmm. And I guess that's a bad place to work as far as drug use. Everyone's telling me kitchens are notorious. Mm-hmm. The lifestyle, they're staying up late. They have a whole different lifestyle, and there's a lot of drug abuse there. Mm-hmm. Not that I'm blaming any situation, but that made it easy for him to get introduced.
Sure.
And he probably found something that made him feel good. Mm-hmm. And then that progressed. He started using prescription opiates that were prescribed to somebody at some point and then got available on the street. And as will happen with a lot of substance abuse, after a while that's not enough. You need something a little stronger. Not to mention heroin is cheaper and easier to get when you run out of the prescription pills. So he started on heroin. At first was smoking it, and eventually he turned to injecting it intravenously.
What experience did you have in terms of trying to find some kind of help for Tim?
Well, we're fortunate in a way. Our family, we had good resources. My wife and I are both medical professionals. And when we saw the symptoms developing at the senior year of high school, depression and anxiety, right away we got to do something about this and get him into treatment. And you know, initially for the mental health part of it, he saw different therapists and intensive outpatient programs, different medications. And then when the substance abuse became apparent, that stepped it up a bit. And for then, we initially tried to get him into rehab. We got to get him away from this, get him clean for a while. And it was very difficult. It actually took 2 weeks to get him into a rehab bed of calling every single morning, sometimes in the afternoon as well.
And this is calling the facility that you wanted to send him to?
Sure. Finding a bed. We don't have anything available, try later or try tomorrow. 2 weeks it took.
And that's as you were mentioning, you're both medical professionals, so you, in some ways, know a little bit about the system and how to navigate it.
Well, I thought we did, but yeah, it didn't work as smoothly as we had hoped. What finally got him in the first time was my wife actually was tearful and begging the admission person, you gotta find something for my son. I don't know how long we can keep him home and keep him away from getting himself into trouble. You know, we were fortunate that one of us was able to stay with him all the time until we got him in, and he finally got in. And then it was followed up by intensive outpatient programs and individual therapy. He did Suboxone for a while too, which is a medication to help with addiction. It reduces the cravings, and it fuels your brain into thinking you're getting opiates without altering your brain. So that you can think clearly, you can function well. He tried that as well, but he relapsed again. He relapsed a few times, and what we've learned is there's no one exact treatment that's going to work for everybody.
Sure.
You know, Suboxone by itself won't work. Intensive outpatient won't work. Just rehab won't work. 12-step programs by himself. It works for some people.
Sure.
Right? But in general, people need a combination of things, and even that doesn't always work. For my son, it didn't. He relapsed after being thrown out of a sober home. After his second rehab, he lived in a sober house for a while, and we didn't even know he was thrown out till the ER. When we got the call, he had overdosed and he was brain dead. And we said, we're in Rockville Hospital. I said, why is he in Rockville Hospital if he was living in a sober house in Manchester? And they said, well, no, he was thrown out 3 days ago because he was positive. You know, and we were just devastated. Didn't know he was living in someone's basement.
Wow.
If we had known he was thrown out, of course I would have been upset.
Right.
We would have taken him in. So I
Right.
said, okay, let's get you back on your feet. But they never even told us, you know, which we had a big problem with the sober homes. You know, they have emergency contacts. Why don't they use it? What's more of an emergency than an opiate addict relapsing?
Right.
But somehow they misunderstand the HIPAA laws and didn't even tell anybody.
Okay.
That he was
And
thrown
how old was he at the time?
He was 29. He was 5 days before his 30th birthday.
Okay, yeah.
And so through Tim's struggle, it's mostly a family organization right now. We're trying to draw other people into it. We developed our nonprofit called Today I Matter. And our mission is to really, twofold. One is to reduce the shame and stigma of both mental illness and addiction. I think, again, it was my son's self-shame that got in his way. He couldn't admit he was thrown out. He couldn't admit he was relapsed. Tim felt like a loser. And he felt everyone saw him that way. He brought a lot of pain on his family. Now, this is a family disease. Everyone suffers.
Right.
And he felt like that was his fault. He brought it on his family. He couldn't even admit he had relapsed again. So one of the things we're trying to do by telling Tim's story, I've done a lot of public speaking, sharing his story to get people to understand, you know, I'm a mental health professional. I've been one for 32 years. It happened to my family.
Yes.
You think you're from a good town, from a good family, it's happening everywhere. If it can happen to my son, it can happen to yours. So by telling his story, I'm trying to put a face on the statistics that we see.
Sure.
Excuse me, about this problem. So I want people going home saying, wow, we got to talk to our kids, we got to talk to our family members. This could happen to us too. And then in addition to that, our second part of the mission is to kind of promote activities that help people, especially young people, feel good about themselves. We're giving 2 scholarships this year at Ellington High School, one for art and one for music, which were things my son loved.
Passions that he had.
Passions that he has. And so we're trying to support that. We have monies available for a kid who's in middle school that wants to take saxophone lessons but can't afford the rental. So we're trying to help kids in the areas that Tim liked.
Sure.
Any activity that could help them feel good about themselves. It doesn't certainly prevent these problems from happening later on, but reduces the odds.
That's wonderful.
So we're a very young organization. We've only been in existence since August.
Okay, so it sounds like you're able to give 2 scholarships. That's wonderful.
Yeah,
So.
we've done
That's
very
wonderful.
well. We've been very lucky with our fundraising.
Sarah and Sean, I wanted to ask about Tim's story. Is that in some ways a very common story that you hear in terms of the workforce? Because I understand, Sarah, that you also sit on the working group.
Yes, I do. And I also identify as a person in long-term recovery and have lost people very close to me. And it's a lot more common, I think, than it even was many years ago. Prescription drugs really were a game changer for this epidemic. I think substance use issues have always been issues forever, but I think that prescription drugs really were a game changer in bringing down people that had many resources and or maybe educational attainments or professional abilities and kind of really knocked the wind out of them. But it's a story that we hear too frequently. You know, I mean, it's...
And we know that 4 out of 5 new heroin users started with prescription opiates.
Wow.
Yeah.
And whether they were their own prescription or diverted prescription from someone else,
Sure.
hear stories all the time. I heard a mom from Simsbury talking about she lost her son to this epidemic. He played hockey, and one of his teammates said, "Hey, dude, take this pill before the game. It'll make you feel great." And that started his path. He never played hockey not being under the influence of some opiate. And it was probably a diverted prescription from that kid's home, the other kid's home.
Right. Wow.
So we have, when we look at the opiate overdose epidemic and we look at the deaths, opiate-involved deaths, the mean age is 40, but we have two clusters. We have sort of 24 to 34-year-olds, which is mostly male, and then we have over 50, which is mostly female. So,
and are most of these also, is there a difference in terms of, you said 4 out of 5 are prescription, entered through either their own or a diverted prescription. Is there a difference in those demographics?
See, we'll never be, never be able to find that out, about where it began. We do know that, the vast majority, about 82% are white, about 70% are male. And again, we have that mean age, and the vast majority of those overdose deaths occurred in a residence. So it's not somebody in a back alley behind a dumpster, it's in people's homes. So
in some ways, it's an epidemic of privilege in some ways.
Yeah, for some, I think, when we do some geospatial mapping with we have researchers at Yale that we work with, and these occurred in all but 17 of our 169 towns.
Yeah, so it is pretty much everywhere.
It is everywhere.
Absolutely.
And I wanted to pull you in, John, because again, you are an APRN, so you are a prescriber, and we were having a fascinating or you can be a prescriber. You're authorized. We were having a fascinating conversation before we came on air about that doctors or prescribers in the state, so they can be APRNs as well, are supposed to be voluntary, or not voluntary, I guess they're mandated to be putting in the information whenever they're prescribing an opioid to somebody. They're supposed to put that information, who the person is and what they were given and when. But as I understand it, not everyone is complying with that. Is that correct?
I think it's only about 20% actually use it on a regular basis.
Prescribers don't put the information into the system. That's done at the pharmacy.
Okay.
But prescribers are supposed to use that as a reference.
Okay.
Before we prescribe, we're supposed to check that system so we know what this person coming into our office already has been prescribed.
Got it. Okay. So
it prevents people what they call doctor shopping. There are people that are desperate for these substances that'll go anywhere they can hope to find it.
So you're seeing the breakdown then is that a lot of the providers, the prescribers, are not taking the time to look at that system.
Unfortunately, they're not. It's available, and it's recommended even as an APRN. For my certification, I have to do that. It's mandatory. But as Sean was saying earlier, there isn't really the oversight to make sure prescribers are actually doing that. I couldn't tell you how many are.
And then there's, on top of that, there's the complication. I believe that you live near the Massachusetts line, and Massachusetts' system, their database basically
Their database is different than what we use in Connecticut and other surrounding states. So I cannot go onto their database and see what they're prescribing in Massachusetts. Which it's very easy for a lot of my clients where I'm located in East Windsor to go right over the state line if that's what they're predisposed to do. Yeah,
sure.
I can't check that.
So I wanted to ask a little bit about both of your organizations. Manchester Hope Initiative, I understand that you partner with Manchester Police Department. Tell us how that works a little bit, Sarah.
Absolutely. So our main goal is to divert people who are dependent on opioids or have opioid use disorder to the treatment system instead of the criminal justice system. And it was essentially based off many unmet treatment needs in our community. And it's pretty powerful when law enforcement is willing to kind of take a stance and say, hey, we're going to treat this issue in as many instances as we can as a disease for what it is than a moral failing or choice of criminal activity. When people are in the midst of especially opioid addiction, it's pretty uncontrollable until that they enter whatever their recovery process is. And I think the fact that law enforcement is starting to finally look at it as such is really powerful.
So it goes back to that stigma that you were talking about, John, as well. Instead of seeing somebody who is addicted and exhibiting that addictive behavior before they're able to get into rehab or back into rehab. instead of looking at them as the bad guy or the person who's done something wrong, as saying it's a flare-up of a disease.
Right. It is. And unfortunately, too, as a person in long-term recovery, I can say that sometimes in the midst of addiction, especially opioid addiction, it's so costly. And there are a lot of behaviors that can happen while someone is in the midst of that a lot of people don't want to be around or might be perceived as antisocial or you know, and while we're not taking self-responsibility off of that, I can say that people most of the people we work with, I think Chief Montminy will say 80% are people that have never had a history of committing crimes unless they were under the influence of opioids. Okay. So when you have people with no prior criminal history, and then when they enter treatment, no present, it says a lot.
One of the problems I think that explains this is a lot of substances, but especially opiates, they actually change your brain and how your brain functions. They change your brain chemistry. They affect the frontal lobe very heavily, which is where your judgment and reasoning comes from. And so we look at people who are stuck in addiction. Why are they lying to their family? Why are they stealing from their own family? That makes no sense. They obviously don't care. What we don't understand is this person is not able to think clearly. They're not able to think things through. They can't see the future. Their day is about, how can I get through today? How can I survive? And it really feels like life and death very often for people stuck in this addiction. I'll do what I need to do for now. I'll have to worry about the other stuff some other time.
Sure.
And it's hard
just
for
a survival
people to understand. Right, it's all survival. It's getting through the day.
And Sean, your organization, AIDS Connecticut, we talked a little bit about this before, but sometimes people say, well, AIDS Connecticut, why is AIDS Connecticut on the working group? But I think the explanation you gave was better than the one I could give, so I'd love for you to share that again.
Sure. So AIDS Connecticut runs a syringe services program, or people know it more commonly as a syringe exchange program, in the city of Hartford. And that's a place where folks who do inject drugs can come. They can bring their used syringes. We safely dispose of them. And they can get clean, sterile syringes and other equipment. We also make condoms available. We can do HIV and Hep C testing right on the van. We can help people get into treatment if that's what they choose. But it's it was a logical step, I think, for us. And we had already been doing some stuff around the opioid overdose epidemic, but some legislation changed a few years ago to make it easier for a prescriber to write a prescription for Narcan or naloxone, which is the antidote to an opioid overdose, and to then make it more accessible. So we formed the work group to create more awareness about Narcan and create more access to it. But even with that, a lot of family members, I remember having a person come to me and say, where can I get Narcan? I said, well, you can get a prescription from your primary care provider. And they just looked at me like deer in headlights. I said, or you can come to my office and I'll give you a brief training and I'll give you an OD kit. Because again, that feeling
barrier
of shame of everything, affects the families as well. Legislation passed 2 years ago that allows pharmacists to take an online training and become certified to prescribe and dispense Narcan. And there was a little bit of a slow uptake with that. The independent pharmacies jumped on it pretty quickly. And now, I forget how many pharmacists have been trained in the state, but now like big chains like CVS and Walgreens are on board. So it should be pretty easy to access Narcan for family members. And I also try to get people to expand their thinking about this. A lot of us feel like Narcan, everybody should have an OD kit in their medicine cabinet.
This is the kit.
This is the kit. In their first aid kit. It should be in all school nurses' office, school-based health centers. It should be alongside AEDs in public places.
All ambulances have this, or?
Yeah, legislation changed a couple years ago that requires all first responders to carry Narcan.
Got it.
So all first responders are armed. We're working to get it on public safety on college campuses. And we've been doing teaching our clients and distributing these kits for about 2.5 years now. Comes with 2 doses of Narcan. It's the nasal version, intranasal version. It has an atomizer in there. It's very easy to put together and administer. And our clients have reversed over 200 overdoses out in the community. And those are the only the ones we know about.
It's amazing.
But this is a medication that has no side effects. You can't get high off of it. The only thing it exists to do is bring somebody out of an opiate overdose and save their life.
Which would otherwise be fatal.
Which would otherwise be fatal. If I gave Sara Narcan right now, nothing would happen to her.
Wow.
We actually have it for the canines at Manchester Police Department.
Really?
Yep. That's how benign it is. They're willing to give it to the canines if
Because when
need
they
be.
go, they're drug sniffing dogs and they go on a raid and they could be exposed
Oh,
to,
sure.
Yeah.
Okay.
which has happened
Never thought of
in
that.
Hartford.
Yes.
Police officers also did a drug raid in Hartford not that long ago, and they did one of those flash bombs, and it blew back some heroin. So a number of the police officers had to go to the emergency room to be monitored for a little bit.
And even with the fentanyl, which is being added a lot to heroin,
Oh, right, to make
it's
it super
absorbed through
deadly.
the skin.
Oh, really? Okay.
Yeah.
So kids, dogs, first responders, even just coming in contact with
Wow.
it in their hands can overdose.
Yes. And people don't know if
dangerous.
the batch that they're taking is going to have fentanyl in it.
It all
obviously.
pretty much, you could be pretty much guaranteed that it's
That
got
it is.
fentanyl. It's coming
Yeah.
to the state with fentanyl in it already. The drug dealers don't even have to cut it here.
Yeah. So let me ask you, certainly in Tim's case, and I've heard this in many, many cases, this shortage of beds in the rehab programs is a real issue. Is that something that the working group is working on, or is that really out of your control?
That's I think the State Alcohol and Drug Policy Council has a little bit of a focus on that. There's 3 subcommittees on that. We're also trying to, again, even talking about who should have Narcan. If you have a prescription for Vicodin, you should have Narcan in your home because anybody can overdose. Anybody who has prescription for long-term pain management, and even though opiates were never intended for long-term pain management, they were intended for end-of-life cancer pain, should have Narcan. But again, people don't know how easy it is to access, so that's part of it. The issue around treatment, and I think a lot of the language and the way people are thinking about this epidemic is changing. Because it's not just people who inject drugs. We're talking about people who have legitimate prescriptions for opiates that should know about Narcan and have access to that and may not. And our language talking about addiction is changing. We move away. We come from a harm reduction perspective. We move away from talking about drug abuse. We talk about people who use drugs or people with a substance use disorder to really go into the disease model. We don't talk about people having clean or dirty urines. Talk about people who might be using, and we want to use that as an opportunity to keep them engaged and talk to them. And also, even with treatment, I think a lot of folks think you have to go to detox, then you have to go to a 28-day inpatient treatment program, then you have to go to a step-down program, you have to go to 90 meetings in 90 days. That doesn't work for everybody. It's not a one-size-fit-all. Everybody's path is different. And so I think treatment programs even are having to change the way they look at things. Because the truth is, they have a 40 to 60% relapse rate.
Yeah.
And when I see that statistic, I don't think, the person's not working their program hard enough. I think, why isn't that program doing something different to treat that person as an individual rather than a cookie-cutter treatment? So I think there's a lot of things that are changing now so that we don't just keep on this same path that we've been on in the past.
We have, I understand we have two minutes left, so I wanted to get some information to our viewers. So if we do have a family that's watching that has somebody who is going through this, how would they navigate, how would they find out about rehab options and Narcan? Maybe each of you can say something quick.
Well, Department of Mental Health and Addiction Services, or DEMAS, has a 1-800 number that's supposed to help people find the treatment options that work best for them.
Do we know that number offhand, or they should look at the website for the Public Health Department in Connecticut?
Department of Mental Health and Addiction Services.
Okay.
DEMAS.
DEMAS, DMHAS, okay.
Right.
They'll also have a link to naloxone prescribing pharmacists for easy access to that.
Also, people can utilize our Facebook page, facebook.com/Manchester CT Hope Initiative, as well. And like Sean was saying, it's the substance, you can just Google substance abuse assessment, I believe is the referral line for that.
Okay.
But as far as for HOPE, people can walk into the Manchester Police Station at any time or go right to Manchester Memorial Hospital.
And John, for families going through this, do you have advice on groups that will help support families going through
Well,
this?
there's certainly groups that are similar to the 12-step groups for people struggling with addiction. There's Al-Anon, which goes for Narcotics Anonymous. That's for Al-Anon is for families.
Okay.
Or Narcanon.
Narcanon,
It's for families of people with narcotics addiction. There's Al-Anon, which is the alcohol branch of that.
Okay.
But there are support groups with people like that too.
Okay.
But two quick recommendations. One, I think if you go on to Google American Society of Addiction Medicine.
Okay.
There are now more physicians being trained in addiction.
Okay.
You start with that person. They can help you figure out what might be the best path for you. What's the level of your use? What might be your best entryway into the system? What level of intensity that you need? But for people who need something now at the moment, if you can't get into a bed, I always recommend call Narcotics Anonymous. You go 211. You can talk to someone tonight.
Got it.
Right away, at least have someone to talk to.
Wonderful.
It's not the answer for everybody, but it gets you connected right away.
Sure.
And then tomorrow, you can start making some calls.
So if you're watching this and you have someone in crisis or you yourself is in crisis, start with 211 and please visit the websites that we have just mentioned as well. I want to thank all of you, John, Sarah, and Sean, for your important work in helping to manage this opioid epidemic and hopefully educate all of us about trying to remove the stigmas and using language more mindfully around this as well. Thank you all.
Thank you.
Thanks so much.
Sure. This has been another episode of the Nonprofit World TV show. I'm your host, Donna Hagigat. Our producer is Sara DeGraff. Our show is taped at Nutmeg TV in Farmington, Connecticut. Thank you for joining us.